Importantly, this field of onco-fertility comes up where we say fertility preservation is extremely important, and it is actually goes for the idiom of better prevention than cure, which means later on it might take doctors, oncologists, gynecologists, or anybody of us who is aware. We must discuss this with them. We may or may not do the fertility preservation, but we must talk about it. So the bottom line that I'm trying to say is that this conversation has to happen before cancer treatment starts. Once even one dose of chemotherapy or something. Hi everyone, you're watching Fertility Fridays with me, Dr. Shweta Goswami, where we try to welcome hope into your families as soon as we can. Today I'd like to discuss a topic which would hopefully affect very few, but it's very important for them, and that is fertility preservation in cancer patients. Now, cancer traditionally had been a disease which was known to happen in the older age group. With coming times, unfortunately, we're seeing an increase in incidence in younger men and women in cancer. Another good thing is that with scientific advancement, we are not only talking about saving people who have cancer with treatments like chemotherapy, radiation. We're also talking about cures, which means there are a lot of cancers where the longevity has increased, where we say they're going to probably have 15, 20 year or even more survivals. So a very important quality of life question has now come up in patients where, when we are daunted by the unfortunate diagnosis of cancer in young women or men, the only thing we're thinking at that time is what are we supposed to do? But because we as doctors know that a lot of these cancers will have long-term survivals, they will survive 15, 20 years, and at that time, a very important question will come up in their mind, because fertility, childbearing, having a child is very important to all our life's essence, and therefore not being able to have a child also comes up as a big question post whatever treatments we do. And it is also a known fact that whether it is chemotherapy, whether it is radiation, it's life-saving and it therefore has to be done. Sometimes surgeries have to be done in the pelvic area, and therefore a big question does come up that how fertile will I be post my cancer treatment. And that's where, importantly, this field of onco-fertility comes up, where we say fertility preservation is extremely important. And it is actually goes for the idiom of better prevention than cure, which means later on, it might take you 2-3 years post-treatment, and we still don't know if those, men and women will have fertility restored or not. And therefore, depending on how much time your oncologist or your cancer specialist will give, we say that this at least discussion must happen, between the patient and the doctor before cancer treatment starts. Unfortunately, it's a very unmet need right now. As I said, usually young men and women are so daunted by the diagnosis itself that nobody discusses that. But, whether it is we as doctors, oncologists, gynecologists, or anybody of us who is aware, we must discuss this with them. We may or may not do the fertility preservation, but we must talk about it. So in short, I'll talk about what are the procedures that can be planned. Now, as far as any post-pubertal male is concerned, which means any male who's above 13-14 years of age, semen cryopreservation is very easy, which means you just ask them to give a semen sample and we can freeze them. If time allows, we tell them to come back for 2-3 days. These semen samples have been scientifically known to be frozen for infinity. You can actually freeze them for more than 20-25 years. So we say it's very simple. Unfortunately, if it is not done timely, then later, these therapies may have caused permanent damage to the gonads and we may not have any sperms left later. It is only in younger boys, pre-pubertal boys, that other experimental strategies, whether we should give them any injections like GnRH analogs, we should consider testicular sperm cryopreservation. So those are rarer treatments that are done. But in short, the take-home message that I would like to say is semen cryopreservation is very, very simple, and any boy or man who hasn't completed childbearing must consider it. It doesn't take a lot of time. It's not very expensive. It's just about doing it right time so that later we don't have a problem. And it's more like an insurance plan. Let's hope you never need it. Let's hope later the reports are all good. But done right now, it will at least give you a lack of anxiety that later what will happen. Coming to women, where it is, broader into all what we can do, we say again, just like we can freeze sperms, we can freeze eggs and embryos. But the catch here is that when you take a semen sample, you find millions of mature sperms and it's very easy to freeze them. the eggs in the ovary are immature. And immature eggs, we still don't have the technology where we can actually use it to produce babies. And therefore, one has to go through the IVF procedure, which means you have to go through 2 weeks. Now, we as fertility specialists need 2 weeks time. We need them to give us 2 weeks time to stimulate them to produce multiple eggs. We need to get the eggs out. Again, the important question, who should do egg freezing, who should do embryo freezing? So we say if you are a single woman, not sure about your partner yet, then yes, we do egg freezing. If somebody is married, then either we do embryo freezing, or we say, okay, we can freeze half eggs and we can freeze half embryos, depending on, your social decision as to what we need to do. So broadly, anybody who doesn't have a male partner should be considering freezing eggs. Somebody who's married preferably freezes embryos. The reason for that being that the embryo cryopreservation is much more successful than egg freezing. So embryo cryopreservation, you freeze 100 embryos, you would get 99 back. You freeze 100 eggs, you'd probably get 80 back. So we see if that is the only option, that's what we do. But definitely we need to, consider it. The other thing is that, the oncologist has to give us at least 2 weeks. So that discussion has to be like, it's, a tumor board kind of a decision, where what we've seen is mostly any treatment that has to be done, until unless it's a very aggressive cancer, you do get a 2-week window. In IVF, the great thing is that earlier we used to have to wait for the cycles to start for somebody to, start IVF stimulation, but now it can be started tomorrow. So I'm not saying we need to do it for sure. I'm saying it depends on which cancer, where it is, what are the chemotherapy or surgical or radiation options we're looking at, where will that be targeted. So it has to be again discussed, but if it is possible, we must consider that. Now, other than this, other treatments, you could have what we call ovarian tissue cryopreservation. We say there is something known as IVM or in vitro maturation. We have GnRH analogs that we give to people. So there are some other treatments that would be needed by some patients. Again, we say we can do ovarian tissue transposition later. We can do a surgery, even if a surgery is being done pelvic area, in the pelvic area, and we can put the ovaries away, that's to save them from radiation. So the bottom line that I'm trying to say is that this conversation has to happen before cancer treatment starts. Once even one dose of chemotherapy or something has been done, we might already have damaged our germ cells. The eggs and sperms are the most vulnerable cells in the body. So my only idea of this video is to educate our audience right there that we must at least have a conversation around it. We may or may not do it, but we must at least definitely discuss it with our gynecologists we know, with our IVF specialists, with our oncologists, and then take a decision on how to move forward. So all the best for that. Thank you. Okay, so we have some questions from our users, and I'd be more than happy to answer them. If you also have any other question regarding this topic or otherwise, please feel free to mention in the comment section below. We will try and reply to them as soon as possible. Thank you. So, एक यूज़र कह रही है, हाय डॉक्टर, मैं बहुत टेंशन में हूँ, मैं प्रेग्नेंट थी, मुझे पता नहीं था, मुझे कुछ रिचुअल्स के लिए बाहर जाना था, तो मैंने 17 से 27 रजिस्ट्रॉन खा ली, और जब मुझे पता चला कि मैं प्रेग्नेंट हूँ तो डॉक्टर के पास गई, तो उन्होंने बोला कि 3rd जेंडर हो सकता है, और अल्ट्रासाउंड रिपोर्ट के हिसाब से मैं 2 प्रेग्नेंट हूँ और तब मैं ले चुकी हूँ, प्लीज टेल मी कि क्या है. सो देखिए, इट्स अ डिफिकल्ट क्वेश्चन आंसर ऑनेस्टली, बट जितना हम देखते हैं रिसर्च में, हम कहते हैं कि अगर हमने इनएडवर्डेंटली दवाई खा ली है, चाहे वो रजिस्ट्रॉन हो, चाहे वो मेप्रेट हो, उसमें कंसर्न हमारा ये होता है, देखिए हम एक रेयर रिस्क समझाना एक डॉक्टर का चांस होता है, बट एक चीज होती है जब हम टेरिटोजेनिसिटी की बात करते हैं तो हम कहते हैं कुछ ड्रग्स हैं जो हमें पता है बच्चे के लिए एबनॉर्मैलिटी कॉज करते हैं, आइसोट्रेटिनोइन, थैलिडोमाइड करके बहुत सारी दवाइयां होती हैं, तो हम कहते हैं उसमें तो कोई सवाल ही पैदा नहीं होता. अगर गलती से हमने प्रेगनेंसी के टाइम खा लिया तो हमें डेफिनेटली मिसकैरेज या अबॉर्शन कराना चाहिए. अब जहां तक प्रोजेस्टेरोन टैबलेट्स का सवाल है, बात परसेंटेज पे आती है, तो हम कहते हैं 99.9% एक्चुअली कुछ दिक्कत नहीं होती है, अगर आप कंटिन्यू करेंगे तो कोई प्रॉब्लम नहीं है. बट एज आई सेड, वो 0.1% चांस हमें लेना पड़ता है, बट यूजुअली मोस्ट प्रेगनेंसीज कैरी ऑन फाइन, बेबीज आर हेल्दी, तो ऐसा कोई एब्सोल्यूट प्रेगनेंसी टर्मिनेशन का इंडिकेशन नहीं होता है इसमें. एक यूजर माई क्रिएटिव वर्क कह रही है, मैम मेरी ड्यूअल मार्कर पॉजिटिव आई है, मुझे कौन सा टेस्ट कराना होगा. देखिए, ये 2 चीजों पे डिपेंड करता है. एक, आपकी एज कितनी है, कोई और हाई रिस्क फैक्टर तो नहीं है. अल्ट्रासाउंड जो NT-NB है किसने किया है, किसी एक्सपर्ट ने किया है तो NT थिक तो नहीं है, या उन्हें कोई और एब्नॉर्मेलिटी तो नहीं दिख रही, क्योंकि अब ये डबल मार्कर टेस्ट तो आ जाता है पॉजिटिव। 1 in 200 का मतलब ये होता है कि 200 में से किसी एक पेशेंट में ही पॉजिटिव होगा, तो 5% पॉपुलेशन में ये प्रॉब्लम आ सकती है। हाउएवर हमें कंफर्मेटरी टेस्ट करना है। अगर हमें बाकी सब कुछ ठीक लग रहा है तो टिपिकली NIPT करके टेस्ट कराया जाता है, जो आजकल 99.9% एक्यूरेट होते हैं। अगर हमारे को कुछ डाउट लग रहा है, चाहे वो एज वाइज है, प्रीवियस हिस्ट्री वाइज है, अल्ट्रासाउंड वाइज है, या इस डबल मार्कर पेरिस बहुत ही हाई है, लाइक से 1 in 20 और समथिंग, तो देन टिपिकली यूजुअली एमनियोसेंटेसिस एडवाइस, क्योंकि एमनियोसेंटेसिस 100% एक्यूरेट होता है। ये ऑल्सो इस चीज पे डिपेंड करता है, ड्यूअल मार्कर आप कह रहे हैं तो मैं अज्यूम कर रही हूँ 13 वीक 6 डेज से पहले होगा, क्योंकि मान लीजिए कभी कभी क्वाड्रुपल या कुछ आता है और हम ऑलरेडी 18-19 वीक्स में हैं, तो हमारे पास NIPT के 2 हफ्ते वेट करके का टाइम नहीं होता है, तो सीधा एमनियो करना होता है। तो ये 3-4 चीजों के डिस्कशन के साथ आपको अपने डॉक्टर के साथ डिसाइड करना चाहिए। एक यूजर कह रही है, I was experiencing heavy breast cramps, backache from first day of embryo transfer, but on 10th day there was no symptom, but on 12th there was again strong pains. Can anyone help me why my symptoms disappear? So we call them, non-specific signs. हम कहते हैं ना symptoms आना या सिम्टम्स चले जाने को हम बहुत रिलायबली कह सकते हैं कि प्रेगनेंसी है कि नहीं है, बिकॉज आई कैन अंडरस्टैंड द मोस्ट इंपॉर्टेंट क्वेश्चन इन योर माइंड इज कि मैं कंसीव कर चुकी हूँ कि नहीं। बट कई बार सिम्टम्स का लौट के आना इज एक्चुअली कंसिडर्ड हेल्दी, क्योंकि हम कहते हैं शायद हमारी ओवरी फिर से हार्मोन्स अच्छे से स्टिमुलेट करिए, इसका मतलब बीटा HCG पॉजिटिव है। ऑन द अदर साइड, हैविंग दीज सिम्टम्स और देम गोइंग अवे कैन ऑल्सो बी मेडिसिन इंड्यूस्ड, हम मेडिसिन जो ले रहे हैं। इन शॉर्ट, एज आई सेड, वी कॉल देम नॉन स्पेसिफिक साइंस। अगर हमारे एम्ब्रियो ट्रांसफर को 10th डे हो ही चुका है या 12 डेज हो चुका है, तो माई एडवाइस वुड बी कि हम एक बीटा HCG करके देखें, या एटलीस्ट घर पे होम प्रेगनेंसी टेस्ट से प्लीज चेक करिए। ऑल द वेरी बेस्ट यू। एक और यूजर कह रही है, हेलो मैम, वेल डिफाइंड, आई एम हैविंग माइल्ड विजाइनल पेन आफ्टर डे 7 ऑफ ET, इज दैट नॉर्मल? सो इन कंटिन्यूएशन ऑफ व्हाट आई जस्ट सेड, थोड़े बहुत पेन्स को हम खराब नहीं मानते हैं। अगर हम किसी चीज के लिए भी चिंतित होते हैं तो होता है कि कोई नेगेटिव सिम्टम तो नहीं है, एंड नेगेटिव सिम्टम हमारी तरफ से स्पॉटिंग या ब्लीडिंग होती है। बैक केक, mild pain are very non-specific symptoms. They can be a symptom of cycle coming in. They can be very much a symptom of healthy pregnancy. तो पेन एक non-specific symptom है, उसकी चिंता ना करें, आप अपनी medications अच्छे से लें, and let's hope that the test comes positive soon. Thank you. So other than that, what I'd like to say is that if you have any other questions, please put it in the comment section. If you want a more detailed discussion at our end, we could do an online consultation as well, for which you could check in the description or go to our website and book it online. I'd be more than happy to help you. Thank you.